And welcome to another session on nerve surgery as part of an educational initiative through the AANS and CNS. My name is Jared Pisapia. I'm a neurosurgeon at Westchester Medical Center. And up until now in the series, we've been mainly hearing from neurosurgeons discussing the diagnosis and management of different peripheral nerve pathologies. Today, we'd like to change gears and hear and learn from our colleagues in related fields, such as pain management, which is today's session, as well as physical medicine and rehab, which will be coming up in a future session. So today, I'm very pleased to welcome close friend and colleague, Ammar Siddiqui. Dr. Siddiqui wears at least two hats, one as an anesthesiologist and another as a pain management physician. He's the program director of the Regional Anesthesiology and the Acute Pain Medicine Fellowship at Westchester Medical Center. And I could say from personal experience that he's an excellent clinician, and it's been a pleasure co-managing patients together on various nerve pathologies. So, Ammar, thank you very much for joining us today and bringing a new perspective from pain management.
Thank you so much, Dr. Pisapia, and again, thank you for allowing me to share my opinions with the fantastic crew that you have over here. So today, the topic we're going to discuss is complex regional pain syndrome, and I sort of chose this topic because there's a little bit of overlap between pain management, between neurosurgery, neurology, and PM&R. It's a diagnosis that we all learned about in medical school, and then we sort of see it a little bit more rarely in practice. But when we see it, it's kind of important to recognize it, and more importantly, when to recognize it's not that. So the ICD-10 definition for CRPS is a chronic neurological syndrome characterized by severe burning pain, edema, and autonomic dysfunction. So unlike most neuropathic pain, there's also physical exam findings, which reflect nerve injury taking on more than just a neuropathic phenotype. There's two types. The first type is called CRPS1. It used to be called reflex sympathetic dystrophy, but that term has fallen out of favor. So this is when you have CRPS-like symptoms, but in the absence of a specific nerve pattern and a specific nerve injury. CRPS type 2 used to be called causalgia. Again, that's another term that's fallen out of favor, but it's associated when there is a specific nerve that's either injured or involved, and after which it presents with CRPS-like symptoms. So, most of us have heard of neuropathic pain, which is nerve-related pain, so kind of burning, tingling, that sort of phenotype. And then nociceptive pain, which is more, sharp aching, more alpha delta fibers. But CRPS is kind of unique because it takes on this form of something called a nociplastic pain. So it's essentially, disturbances in pain processing that are not completely explained by structural tissue changes or separate nerve disease. So the kind of easy way to think about it is that there is, it's a nociceptive injury causes neuropathic-like pain. And it's harder to diagnose it because it's not related to the pattern that we typically see with nociceptive or neuropathic pain. Diagnosis can be challenging. So, these patients have normal nerve conduction studies. It's not so much that the nerve is injured, it's just that the nerve is injured and it has sequelae from wind-up. The main factor is pain to mild blunt pressure. So if you touch the nerve, even gently, you have a severe reaction to the pain. It's accompanied by hyperesthesia, burning. So when you have patients who put their clothes on, it hurts a lot, and that's sort of the defining characteristic. For diagnosis, there are these physical exam and history findings, which are called the Budapest criteria. So you have to have physical exam findings in 2 or 4 categories: sensory, vasomotor, pseudomotor, or essentially edema, or motor or trophic. So if you have muscle wasting or if you have weakness, that is what they're referring to by motor or trophic. More recently, they came out with the Valencia guidelines because autonomic symptoms, so swelling, warmth in the arm, can resolve after a little bit of time. But even if they were present earlier in the disease course, they are accepted as a factor in the Budapest criteria. The Budapest criteria are about 99% sensitive for detecting CRPS, but the specificity is fairly low. It's about 70%. And the main reason for this is, as we'll see in a second, there's many other conditions that can mimic the symptoms of CRPS, and it's kind of important to rule those out before giving a patient a diagnosis of CRPS. And it's sort of an important thing is that, even if for CRPS2 specifically, if you have a single nerve that's involved, so for example, the common peroneal nerve, over time, CRPS can start to affect the rest of the leg, even in dermatome, even in areas that are not supplied by the affected nerve. So these are the Budapest criteria. So, the first is chronic pain in a limb that has been persistent or recurrent for longer than 3 months is present. Number 2, the pain is associated with at least one symptom in 3 or 4 categories. So you can see how complex it starts to become, right? So the first is sensory. So you either have hyperalgesia, which is increased sensitivity to touch, or allodynia, which is weakness, which is pain to touch. Sorry. Number 2 is vasomotor. So if you have temperature asymmetry, so if the blood pressure is either high, if the temperature is either higher or lower. If you have skin color changes, so sometimes these patients are going to have skin that's a little bit more red, or that's a little bit more blue. Number 3 is pseudomotor or edema. So you can have edema. Some patients can either sweat more or sweat less. Can have motor atrophic changes, so skin changes. So you can have decreased range of motion, motor dysfunctions. You can have tremors, dystonia, or you can see that the skin becomes more shiny, the hair starts to fall off, the nails start to fall off, and those are all atrophic changes. Number 3, so the patient must have at least one sign at the time of evaluation in 2 or more of 4 categories. So number 1, sensory. So the first two factors are signs, and the next 2 factors are symptoms. So they have to have hyperalgesia to pinprick or allodynia to light shot. So rather than just the patient saying they have their clothes hurt, you have to actually check it out with your exam findings. So you have to touch them. Sometimes you apply deeper pressure, or if there's joint involvement, that can be one other thing. Number 2 is vasomotor. So if there's temperature asymmetry, so you can take a small thermometer and put it on one side and on another side and see if that changes things. And then just on exam, if they have skin color changes or skin color asymmetry, that's the other physical exam finding. Pseudomotor or edema. So, again, if you can visualize edema, if one side is more swollen than the other, and you've ruled out, a DVT or other things. Sweating changes, if there's sweating asymmetry. And then motor atrophic changes. So, again, same thing. So a decreased range of motion, motor dysfunction, or changes in the skin. And then this is sort of a newer one, but the pain is associated with at least one of two categories. So emotional distress, which is almost always present, and then interference with daily life activities and social participation, which is also frequently present. But the last one is the most important one, is that the pain cannot be better explained by another condition. And we'll get to that in a second with the differential. So differential. So again, you hear about motor changes, you hear about swelling, redness, pain. So things you think about are a fracture. You can have compartment syndrome, which as we learned in medical school, for sort of presenting signs or pallor, pain, pulselessness, and then in paresthesia. Nerve pain itself can somewhat mimic CRPS, but it's kind of important that CRPS is usually a sequelae of nerve pain, not caused by it. And this is the big one. So infection. So frequently, we will get referrals from orthopedic surgery on patients who had joint surgeries, and they have swelling, they have warmth in the joint, they have redness in the joint. Because of the pain, they're limited in how much they can use the joint, and so motor changes. And I think it's very important to make sure there's no infection happening, because the presentation is very similar. You can have arterial insufficiency, you can have Raynaud's, so the color changes, the motor changes can also be caused by Raynaud's itself. And then this is kind of a bigger one that's kind of gained a lot more prevalence. I think it's important to remember that CRPS itself is a fairly rare disease. There is, not that it doesn't exist, it absolutely does, but it's because the diagnosis is so subjective. It can be financially an incentive for certain people to diagnose it because once it's diagnosed, the therapies that can be applied to it can be very lucrative sometimes. So there's, obviously doctors do the right thing, but there's sometimes a secondary incentive to the diagnosis. Um, you also have to worry about, harm to self or others. So if you're seeing, a sort of common case of this is Munchausen's by proxy. So, if you're seeing patients who have, swelling in their arms, if they have skin changes, you sort of have to keep it in the back of the mind that CRPS is, people know what CRPS is. And sometimes it can be, there can be insidious factors going on in presentation. You have to worry about fraud, right? Because again, CRPS can be a lucrative diagnosis, and you have to kind of wonder if it's being overdiagnosed for that reason. And then certain times there's unknown causes, and you have to keep that in the back of your mind too. So early versus late CRPS. So in the first few months of CRPS, you see different symptoms than the last few months. And this table, which is from JAMA, kind of goes over that. So early CRPS is the typical CRPS. So, swelling, pain, motor dysfunction, this mottled discoloration, painful sensitivity, abnormal hair growth, abnormal sweating, temperature changes. But over time, most CRPS resolve. So over the course of 8 months, as you can see on this graph, most of the time, CRPS will get better, and about 80% of the time, it's going to be gone within 18 months. But sometimes patients have persistent CRPS, where the allodynia persists, the motor dysfunction persists, and the painful sensitivity persists. However, the vasomotor changes, the sympathetic changes get better over time. So the swelling goes away, the discoloration goes away, the temperature changes go away. And then what you're left with is really motor changes, and that's why the number one goal of management is physical therapy. So again, 80% of patients are going to get better within 18 months. But what's important is that because of the pain and because of the weakness that might be associated with CRPS, patients can stop moving. So if it hurts to move your arm, if it hurts to walk, it's very tempting for patients to not do those anymore. And the main problem with that is if you stop moving, the weakness will persist beyond when the pain symptoms will get better. So the entire focus on CRPS management initially is on desensitization. So if something hurts, getting to a point where it doesn't hurt anymore, and when you're used to the pain, so that you can power through the pain. And then preservation of function, so making sure you're completing your range of motion activities, making sure you're walking, making sure you're able to move the leg the leg or arm, the limb that hasn't been moved. And for this, you usually need help because it hurts a lot. So a good physical therapist goes a very long way in making sure you preserve function. So most of the interventions that we do in chronic pain are aimed at helping patients complete physical therapy. And so, this is kind of a nice list that's from a paper that I'll cite later. But essentially, these are the different symptoms that can happen, and these are the first-line treatments that we use for them. So if a patient has mild to moderate pain that's limiting their ability to do physical therapy, then we just do, simple analgesics. Sometimes we'll do blocks, but usually it's just simple analgesics. So, Tylenol, NSAIDs, and they usually do the trick. If it's really bad, excruciating, intractable pain, then sometimes opioids are indicated. I don't love doing that, but sometimes you need to, just to make sure that patients are able to complete physical therapy. Sometimes we'll also do sympathetic blocks, where we essentially do a sympathectomy on either the arm or the leg. And again, the main benefit of this is it's going to be short term. It's a block, but it allows them to do physical therapy, which is really what's going to help long term. If they have inflammation, swelling, and edema, so those vasomotor changes we were talking about, sometimes steroids can be helpful. Sometimes you can do NSAIDs. Sometimes you can do immediate modulators. The data about all these medications is not great. It's pain. Pain has two components. So pain has, the component, the physical component where it hurts, but it's also an emotional component. So you want to make sure you're addressing, underlying symptoms that are caused by the pain, because it's sort of a vicious cycle. So if you're depressed or anxious or you're not sleeping, then it's going to make, because of that, it's going to heighten the pain levels. And then when the pain levels are heightened, it's going to worsen the depression, anxiety, and insomnia, and they kind of go hand in hand. So sometimes they need, antidepressants or duloxetine, for example. Psychotherapy is very helpful. We have pain psychologists we refer to all the time. They recommend sedatives. I'm hesitant to give sedatives to patients just because I'm not a big fan of people, using artificial methods to go to sleep. But if it's needed, some practitioners will prescribe it. And then if there's allodynias or hyperalgesia, if the nerve component is higher, then anticonvulsants, so gabapentin, pregabalin, sodium channel blockers, or even ketamine, which I'll get to in a second, can be used for this. If you have osteopenia, which is associated with CRPS, if you're immobile, if your stroke exchanges, calcitonin and bisphosphonates have some evidence behind them. Not great, but there is some evidence and they're fairly safe. And then if there's severe vasomotor disturbance, then calcium channel blockers, the sympatol-like fix, may be indicated. So ketamine is an interesting one. So ketamine has been used in CRPS for a long time. One of the first ketamine studies was in the Journal of Vascular Anesthesia, but that was retracted about 10 years later because it turned out the author, they had manufactured both their credentials and some of the data. But the big study that we kind of referred to is this study from, I think it was in Germany, but they essentially took 20 patients with severe CRPS, and then they induced them with anesthetic doses of ketamine, and they intubated them for 5 days in the ICU with anesthetic doses of ketamine. So they were kept intubated for 5 days, receiving, ketamine, enough ketamine to put them, keep them tranquilized, essentially. Obviously, that would be a very interesting study to get past the IRB these days, but I guess Germany has a more flexible IRB system than we do. What they found was that most components of pain did get better after ketamine, and it stayed better 6 months down the line. So their activities of daily living got better, their social integrity score got better, and their ability to work got better, and it stayed better for a long time. So that's how ketamine kind of got introduced. Over time, we stopped using anesthetic doses of ketamine and started using analgesic doses of ketamine. So you're still awake. You might be a little bit sleepier, a little bit more confused, but you're still awake and you're still breathing, which is important. You don't need an endotracheal tube or an ICU. And that sort of led to the development of these ketamine clinics where there's your outpatient clinics where you go in, you get an IV, you get ketamine, and you go home, which are fairly, maybe a cost-effective option. But for most patients, getting admitted to the hospital and getting a ketamine infusion is not cost-effective. Ketamine and CRPS came into the Netflix arena with this documentary called Take Care of Maya. This was a pediatric patient who had refractory CRPS. She tried everything, and then ultimately she went to Mexico to get a fairly high dose of ketamine, much higher than most physicians would be willing to give. So that helped her. But then she had a CRPS exacerbation later on in the United States, and then she went to the ER. For the pain flare, she was admitted to the ICU, and then the parents kept asking for higher and higher dose of ketamine, which she supposedly received in Mexico, and the doctors and nurses felt like that was inappropriate, and that might have been, they were uncomfortable with that dose, and they felt like it might be, more harmful for the patient than beneficial. They called Child Protective Services. The parents were the child was taken away from the parents, and then she was basically kept in the hospital while undergoing treatment while the parents were at home. It ended up becoming a lawsuit, and the courts delivered a $260 million verdict against the hospital in 2023. But if you'd like to learn more, please get a Netflix subscription. I do not get any money from Netflix for this. Interventions. So, these are minimally invasive. So we do nerve blocks. So we'll just, if you're having pain in your foot, we can do a sciatic nerve block. The problem with nerve blocks for most of the time is that you lose motor function as well as sensory function. So when we do these nerve blocks, you get, you lose motor, you lose sensory, and you also have a sympathetic blockade. But certain blocks only have sympathetic blockade without the motor or sensory loss. So the big ones are a stellate ganglion block, which is done in the neck, or CRPS of the arm, or the lumbar sympathetic block, which is done under fluoroscopy in the background, L1-2 or L2-3. And that the goal of all of these is to really get the pain to a level where patients can do physical therapy. We do peripheral nerve infusions. So, sometimes patients will be admitted with CRPS. They'll get a peripheral nerve catheter. They have to be admitted to the hospital for this. But the idea is that it kind of resets everything, and then the CRPS symptoms get better. Not much data behind this. It's something that's done, and it's, anecdotally, it's been helpful. But there's not much data behind it. Spinal cord or industrial root ganglion stimulation can be helpful, and I'll talk about that in a second. And then if all else fails, then sympathectomy or a motor cortex stimulation can be helpful as well. So this was the ACURATE trial. So this was a trial that was published in Pain Medicine, in Pain, the journal Pain, where they compared dorsal root ganglion stimulation to dorsal column stimulation. So dorsal column stimulation is traditional spinal cord stimulation. It's the image on B, but essentially you put a lead up into the thoracic spine, to the lumbar spine, and you stimulate the dorsal column, and you try to essentially use gate theory to turn the pain sensation off. And it's pretty effective for CRPS if it is CRPS. CRPS is one of the indications that it's approved for. Option B is something called dorsal column stimulation. So it's a little bit trickier because you have to put in a lead, but have it essentially loop around the nerve root itself. So a little more challenging, a lot more fluoro time. But the study did compare them and had a fairly big group, and they did show that DRG was a little bit more effective compared to dorsal column stimulation at all time points. And this was on 152 patients with CRPS. That's all I have. So these are my references, and I will take questions, Dr. Pisapia, if you have any.
All right, well, thank you so much. That was very informative and a great overview. Just a quick question. You touched on sympathetic blockade. Do you ever find subsets of patients with CRPS maybe better candidates for that procedure if they have certain signs or symptoms?
Yeah, I think it's a great question. So in my experience, the patients who benefit the most are the ones who have vasomotor changes, because a sympathectomy blocks a lot of the input to vasomotor changes, and it can sometimes be helpful. The goal with sympathetic blocks is always physical therapy. So, what really helps these patients, what they really need is desensitization and preserving motor function. And the goal with sympathetic blocks is going to be to allow them to do physical therapy, because sympathetic blocks, ultimately what we use is local anesthesia, and sometimes we use steroids. And, the effects for those are not going to be very long. Maybe you'll get, a few days to a month out of them if you're lucky. But by doing physical therapy and by desensitizing, that's when you can justify doing those blocks on patients. And those are the patients that benefit the most.
Excellent. And you mentioned that in some cases, CRPS will resolve, up to maybe 18 months. Just can you give us a feel for timing of when some of these interventions occur, whether it's oral medicine blocks? At which time point would you intervene if you see a patient very early in their course?
Yeah, I mean, that's a great question. I think I would certainly try conservative therapy first. So oral analgesics, gabapentin if it's more allodynia. But if that doesn't help, and if they're unable to do physical therapy, then I intervene early. If they're able to get through physical therapy, I really sort of strongly believe that oral analgesics are enough. Uh, but it's really, the earlier they can do physical therapy, the better the outcomes are going to be. Because the longer they wait, the more atrophy they can have, the more they can have adhesions in their joints. And it's harder and harder. The longer they wait to start physical therapy and to complete physical therapy, uh, the harder it's going to be for them to start. And so there's an argument to be made for patients who are resistant to conservative management to do these blocks earlier on.
Great, great. So really, it sounds like getting into physical therapy is really the key here. Yeah. All right, wonderful. Well, thank you again for your time. That was very informative, and we appreciate it.
My pleasure. Thank you so much.
Take care.